Welcome to Pediatric Grand Rounds. This morning we have got Dr. Sabeen Habib. She was here a few years back and left, and then she decided that she really wanted to be here, and here is home. So welcome back home, Dr. Habib, and teach us about the kidney beans.
I will try my best. Okay, can you guys hear me? All right. So, first of all, I will apologize by saying that I did try this new background, and I realized after having corrected all the fonts and all the sizes that when I went home and was revising it last night on my own computer, the fonts were all funky. So if they show up funky, I apologize in advance. Okay, so we're going to talk about hematuria and proteinuria at a general practitioner level. Because I feel it is very important to have that basic knowledge to be able to know when to refer your patients and when not to refer your patients. Feel free to interject in the middle. Feel free to wait till the end to ask questions, whatever you feel like doing. I don't get bothered by any of that. Okay, so we're going to start by talking about, well, I have no disclosures. We'll start by talking about proteinuria, then we'll talk about different kinds of hematuria, and then when to refer and when not to refer. Okay, so starting with proteinuria. What is proteinuria? So does everybody have proteinuria?
Under the right circumstances.
Yes. Actually, everybody does have proteinuria, but the amount of proteinuria we have is under the limit of the detection by the dipsticks or by if you send it to the lab, because less than 100 milligrams per meter square in 24 hours. So all of us at adults, 1.7 meters square. So 170 to 200 milligrams in 24 hours is normal amounts of proteinuria. Okay, so there is proteinuria, but it's normal. So when it gets abnormal is when we worry about it. When it's too high and it is detectable by the dipsticks. Okay? All right, so you can have non-pathologic proteinuria even when it's abnormal amount of proteinuria, and you can have pathologic amounts of proteinuria. Non-pathologic is orthostatic proteinuria. Orthostatic proteinuria is when you're up and walking around, you will spill protein in the urine, but when you're laying in bed, you will not spill protein in the urine. More common in your preteens and teens, so out of the blue, they come in and you're getting a dipstick for some odd reason, and if they have protein in the urine, otherwise not swollen, you want to check a first morning urine in those patients. Okay, and we'll talk about it a little bit more in a second. When you have fever, any of us, including kids, can have protein in the urine. It goes away when the fever goes away. So again, if you have protein, if you're just checking a urine analysis to make sure somebody has a urinary tract infection or not when they show up for fever, and if they have protein in the urine, but they're not otherwise swollen, I would just recheck when they're better. And sometimes you can have exercise induced, and the way you figure that out in your office is that if somebody comes in and says, hey, so-and-so said I had protein in my urine after, I don't know why they would check it, but after they checked it after exercise and there's none in your office, you can make them run around and then check the urine again, and then they will have protein in the urine. And all of this, since this is transient proteinuria, is not harmful to the kidney. And the reason why we worry about protein in the urine in excessive amounts is because it is harmful to the kidney if it's in excessive and abnormal amounts, which is where it is persistent and it is pathologic. It can be from your tubules, where there's an abnormality in the cells where they're very porous and pouring out protein, or it can be glomerular, where there's changes in the glomerular basement membrane, which is why protein is being leaked. That can be because of systemic diseases like hypertension, diabetes, or it can be secondary to nephrotic syndrome and other renal pathologies. All right, can you all read this? I know it's a little bit small. Can one of you read it?
A 15-year-old boy received for a health supervision visit. The patient is healthy with normal growth parameters and development. He has no significant past medical or past physical history. Physical exam and vital signs are unremarkable. His urine analysis in the office reveals a specific gravity of 17010, age of 6, 4+ protein and no blood, leukocyte asteroids or nitrates. His parents recall that their son had protein in his urine during a sports physical last year. following the best next step in management is A, evaluation by a nephrologist, B, evaluation of a first morning urine sample, C, quantitative urine protein estimation of a 24-hour urine sample, D, recheck at the next health supervision visit, E, urine microalbumin estimation of 24-hour urine sample.
Any thoughts, anyone? You can be loud, it's okay. B, yes. So since I kind of leaked this answer a few slides ago. So you want to take a first morning urine, right? Because he's otherwise healthy, there's nothing wrong with him. And but all of these questions that you will see in this presentation are all from prep. So for the students and residents here, these are all work questions. Okay. So persistent asymptomatic proteinuria, you kind of want to first rule out their orthostatic proteinuria or exercise-induced proteinuria, right? So the first thing you would want to do is you want to make sure you check a first morning protein creatinine ratio. So, and the way you do that is you have to explain to the patients, because it doesn't mean that it's the first urine of the day, it's when they first get up and they pee. Because as soon as they've started walking around, they may just very well start spilling protein again, and it might not be a true first morning urine. You have to explain to them, as soon as you wake up in the morning, don't eat breakfast first, don't be on your phone for 1 hour before you get out of bed, just go pee in a cup, and then send that cup off to the lab to check a protein creatinine ratio, which is a ratio between urine protein and urine creatinine, and gives you a normalized value as opposed to just a random protein value. And the normal urine protein creatinine ratio is I hear a point something. 0.2 is normal. Less than 0.2 is normal. Greater than 2 is nephrotic. In the middle is a gray area. Okay, so you first rule that out, and if you have persistent proteinuria, even when you do your first morning urine, then you want to investigate more. And usually, especially if it's significant, then you would need a kidney biopsy to figure out what it is so that you can treat it and decrease the amount of proteinuria and prolong the life of the kidney. And renal biopsy is usually indicated unless there's other reasons such as long-standing diabetes or HIV or chronic hepatitis B, which we don't usually see in our pediatric population, but we do have med peds here, so it would be important for them. One other question. There's many questions.
A 4-year-old boy is seen in the emergency department because of recurrent facial swelling. The mother reports that the boy has been evaluated by a pediatrician on several occasions with a similar complaint. Each time the boy was treated with 3 to 5 day courses of antihistamine or oral steroid. The mother maintains full adherence with these treatment recommendations. Physical exam shows a healthy appearing boy with normal growth parameters. He is afebrile with a respiratory rate of 18 breaths per minute, heart rate of 84 beats per minute, and a blood pressure of 90/60. The only finding of significance is facial puffiness and periorbital edema. Of the following the most appropriate next step in this treatment.
B, obtain a urinalysis. What do you think is going on? Nephrotic syndrome. We'll talk about why you can't tell if it's minimal change or not. Minimal change disease. So we'll talk about it now. Minimal change disease. What do you think how do you find out if somebody has minimal change disease? Biopsy. Are we biopsying all of these kids? No. So it used to be very common that we used to call them all minimal change disease, but we're steering away from that and sticking more to clinical terms like idiopathic nephrotic syndrome, or steroid-responsive nephrotic syndrome, or steroid-resistant nephrotic syndrome, frequently relapsing, in all of those terms. Because unless you biopsy them, you're just assuming that it's minimal change, right? So we're kind of steering away from that. But yes, nephrotic syndrome is what this is. One more question.
A 12-year-old girl comes to your office with the chief concern of fever for 1 day. She has had mild abdominal pain since the morning and 1 episode of non-bilious vomiting 4 hours ago. She denies any cough, nasal congestion, or painful urination. Her evaluation reveals a temperature of 38.9 degrees Celsius, heart rate of 86 beats per minute, respiratory rate of 16 breaths per minute, and blood pressure of 98/50, and normal growth parameters. Her physical examination is only significant for mild discomfort on abdominal palpation in the periumbilical region, with no organomegaly, flank tenderness, guarding, or rebound tenderness. Her urine analysis demonstrates a specific gravity of 1.025, pH of 6.0, 2 plus protein, and no blood, glucosinogesterates or nitrates. Of the following, the most likely cause of proteinuria in this patient is
C, febrile proteinuria. So this is your classic where you're like, don't necessarily have to worry about as long as there are no other signs of her having nephrotic syndrome. Now, if it was the same scenario, but she had significant ascites and periorbital edema and 3 plus pitting edema and abdominal pain, then yes, this was likely nephrotic syndrome along with peritonitis, right? So you kind of have to look at it as a whole picture and not just one value. Come on, there's plenty of you.
15-year-old adolescent girl returns to the office for evaluation of proteinuria and undergoes 2 health supervision visits a year apart. Today, her temperature is 37.9, heart rate is 76 beats per minute, respiratory rate is 17 breaths per minute, and blood pressure is 110 over 60. She has the normal growth parameters, normal physical exam findings, currently menstruating. Her UA 1 year ago was only significant for 1 plus proteinuria. Her UA today demonstrates a specific gravity of 1035, pH of 6.0, 3 plus protein, 4 plus blood, and no leukocyte esterase or nitrates. Urine microscopy shows greater than 100 red blood cells per high power field, less than 5 white cells per high power field, and versus the bacteria. Of the following, most appropriate next step in evaluation is first morning UA, urine microalbumin, urine creatinine the next day. First morning UA, urine protein, urine creatinine the next day. First morning UA, urine protein, urine creatinine, not menstruating. 24-hour urine collection for microalbumin, but not menstruating. And 24-hour urine collection for protein excretion, not menstruating.
See? There have been quite a few studies, especially in pediatrics, that have shown that a random urine protein creatinine ratio is fairly comparable to a 24-hour urine collection, which is hard to do in our younger kids anyway. So it's easier just to do a urine protein creatinine ratio, but you want to wait till she's not menstruating so that you can get there. So nephrotic syndrome is what we're talking about, and the reason why nephrotic syndrome happens is that normally your podocytes maintain your glomerular basement membrane, and in most cases in nephrotic syndrome, that the podocyte membrane podocytes in the membrane are altered, and sometimes you can get mutations in the podocyte proteins such as nephrin and podosin, which results in congenital nephrotic syndrome, which is important to know because when you have a genetic malformation which is resulting in nephrin and podosin mutations, then they will not respond to steroids at all. Most of those kids, though, will present earlier on in life, usually by the first year of life, if not the second year of life. Sometimes they're born puffy. Very common very common type is the Finnish type of congenital nephrotic syndrome, which is common wherever there are Amish populations. So Pennsylvania, Ohio, upstate New York, those are places where you see all of this a lot. The important reason to recognize it, because no matter how much steroids you give them, they will not respond because they can't fix the problem because it's genetic. And in those cases, you basically have to use other symptomatic therapies till essentially their kidneys go into renal failure and then you transplant them. But for other types that are non-genetic, you can start with treating them with steroids. So basically what happens in nephrotic syndrome is, and we have, so this is your normal capillary and this is your nephrotic capillary. And what happens is, since you've lost your oncotic pressure because you were spilling out all the protein, your fluid does not necessarily stay in your capillaries like it's supposed to, and it third spaces. That is also an important concept to understand, because the fluid that you have accumulated in your body during nephrotic syndrome is third space, so it's in your tissues, it's not in your vessels. And essentially your vessels are dry, right? They have blood, but it's concentrated blood because your fluid is kind of out third space. So if you were just to give them Lasix or try to diurese them, where will Lasix act? On the blood vessels, not on the tissues. So it's not going to help you much, and it's actually going to make them more dehydrated, so to speak, intravascularly. So you kind of have to pull that fluid into the vessels and then diurese them so that you can actually fix their edema. Okay. So, which is kind of explained right here. So you have your increased glomerular permeability because of proteinuria. There is efflux of salt and water in the tissues, which results in edema. Then you have decreased blood volume, which results in decreased renal blood flow in GFR, which also causes decreased secretion of salt and water. And then you have your increased synthesis of lipoprotein, which results in the hypercholesterolemia, which is the fourth criteria when you look at the clinical criteria for nephrotic syndrome. More important also is that you don't necessarily have to treat this hypercholesterolemia if you know that you can treat their nephrotic syndrome. Because as soon as you treat their nephrotic syndrome and they're no longer proteinuric, eventually this lipoprotein synthesis will decrease and they will improve their hypercholesterolemia. Okay, so you would, the clinical presentation of nephrotic syndrome is periorbital edema. The question that we saw where the kid had a bunch of days of allergy medications, et cetera, is very common. Because initially they might just present with puffy eyes, and especially if it's a season where allergies are more common, then they might be labeled as having seasonal allergies and tried on allergy medicines and it's not getting better. And it might not be till they present with more edema at other places in their body or somebody checks a urine analysis or thinks about it that it's common. There have been a couple of times that I have actually seen kids come in with respiratory distress because they had developed significant fluid overload and pulmonary edema and were being treated as an asthmatic but actually had nephrotic syndrome. So you have to have an index of suspicion. Again, it comes with getting the whole history and looking at the whole picture and not just focusing on one symptom. They usually will have gravity-dependent edema, they'll have ascites, they'll have pleural effusions. They can have poor appetite because they're not only is they're puffy outside, they're puffy inside too, right? So their gut lining is puffy, they don't feel like eating, they're irritable, they're miserable because they're swollen and they can't walk, they can't sit, they're not comfortable in any position. They will have a urine protein creatinine ratio which will be greater than 2. You do not have to check a 24-hour urine in those patients at all. Certainly don't need to insert a Foley to get a 24-hour urine in any of the younger kids. Their serum albumin will be low, they'll have hyperlipidemia, and they may have microscopic hematuria as well. About 50% of your nephrotic syndromes will have microscopic hematuria. So again, as soon as you see hematuria, you think that maybe this is glomerulonephritis, but you kind of have to look at the bigger picture and see where all of this is falling into. So this is I have a couple of pictures of what your edematous nephrotic syndrome kids might look like, though I hear that there might be an admit last night, so I guess you guys can see firsthand if you are on the wards. And significant edema in their legs. Little boys will have scrotums that will be awfully swollen. Sometimes they get so swollen that they can develop cellulitis in those areas. More important, again, to relieve that swelling, no matter how much Lasix and albumin you give those kids, you have to elevate their scrotal area so that the fluid gets to the rest of the body to be diuresed. Nephrotic syndrome is about 2 new cases per 100,000 children less than 16 years per year. Males more than females. Most common age is between 2 to 6 years. When they present later on in life as a new onset nephrotic syndrome, then the likelihood of them having anything other than what we used to label as minimal change disease is higher. So those cases we tend to biopsy them sooner rather than later. And then the incidence is higher in Asian children, more common in white than black or Hispanic kids. Also, if you have, you will see a lot of times in their histories that they'll either have reactive airway disease or other allergies when they present with nephrotic syndrome. So you can have your primary nephrotic syndrome and your secondary nephrotic syndrome. Your primaries are what we call as minimal change disease. It is essentially minimal change disease because when you look at these kids and then you biopsy these kids and look at their kidneys under the microscope, you see no changes except for podocyte foot process effacement in electron microscopy. And that is where the name minimal change disease comes from. Then there'll be mesangial-proliferative. Again, all of these are biopsy diagnoses. Membranous nephropathy, membranoproliferative and other nephropathies. All of those actually require biopsies. Secondary causes can be secondary to systemic diseases. The most common you will see in our pediatric population is either lupus or HSP or IgA nephropathy. Malignancies can also cause you to have nephrotic syndrome. Our med colleagues probably see that more than, thankfully, we do in pediatrics. Infections can be responsible for nephrotic syndrome, drugs, allergens. There have been a couple of times that we've seen drug-related nephrotic syndromes here in the past. So you can have infections, and the reason you can have infections is they're spilling protein, right? They're spilling tons of protein. They're spilling all kinds of immunoglobulins, all kinds of antibodies, and by definition, even before you put them on high-dose steroids, they're immunosuppressed. So they are definitely prone to infections. Plus, they have fluid in places where fluid doesn't belong. And when fluid is in places where it doesn't belong, it can get infected. So they can get peritonitis, cellulitis, all kinds of infections. They can have thrombosis because remember, their fluid is extravascular. So intravascularly, they are dry, which means they can be prone to thrombosis. Also because they're losing their anticoagulant factors while they're losing all their proteins as well. They're hyperlipidemic. They will not grow, especially if they have recurrence of nephrotic syndrome and are on steroids a lot more than not. And they can go into renal failure. So how do you treat them? You restrict their sodium. Why do you restrict their sodium? What happens when you eat salt? You get thirsty, right? When you drink water. Where will that water go in these kids? Third space. So the more salt they eat, the more water they will drink, and the more fluid will get third space. If you just tell them to fluid restrict their kids, it's not going to work. You actually need to decrease the amount of salt because bags of chips and Cheetos are the kids' favorite things, right? So you kind of have to limit that, if you want to restrict the amount of fluid they will drink. A lot of times what happens is we admit them to the hospital and we put them on a low salt diet. They're in a controlled environment and we squeeze them dry and we send them home and start them on steroids. Steroids take a couple of weeks to start working anyway, right? But you get a call the very next day that says that, oh, the medicine is not working and they're swollen again. What happened? They went home and they ate a bag of chips and they drank tons of water and now they're swollen again. So, and this happens despite of us educating them about it, but it is a very common phone call to get. So education, again, is very important, explaining the reasons why you're doing it, and you're not just trying to torture these kids by telling them don't eat chips for a little while. You can give them diuretics, but again, diuretics are a band-aid because they only work on the intravascular spaces. So you really just need to try and fix the problems. Anticoagulant medications are usually not used, but you just have to caution the parents and educate them about the different kinds of symptoms of thrombotic events. So most commonly you will use, and I'm sorry, that's a typo, that's 2 milligrams per kilogram is what it should say right here. For minimal change disease, you use 2 milligrams per kilogram, which is 40 milligrams you can do BID or once a day. There was a while there were studies that if you split the dose into twice a day, then it is more efficacious. But we all know that any medication that somebody has to give twice a day will likely not be given. So if you can get it into them once a day, it's better. You treat them like that for 4 to 6 weeks, especially if it's a first episode, and then you switch them to 1.5 milligrams per kilogram after that, and then you kind of wean it off. There are different ways to treat nephrotic syndrome the first time and then subsequent time, and everybody varies on depending on which study they decide to follow. So it may vary from whether you're here or whether it's me or Dr. Baliga or you go somewhere else and they treat it completely differently. But there are usually studies to back up what everybody's doing, and it's just what you follow. Again, if we don't have a crystal ball, we have no idea. But the theory behind increasing the duration of steroids the first time you have nephrotic syndrome is that there were studies that said that then there was less chances of subsequent relapses, which more than 50% likely will have at least one relapse. So 60% of your patients will respond in 2 weeks, 85% in 4 weeks, and 95% in 6 weeks. This is really important because when you start them on steroids and you send them home, you need to explain to the parents that it's going to take a couple of weeks for this pill to start working. So till then, we still have to fluid restrict, we still have to salt restrict, we have to kind of keep using our Band-Aids till they get better. So if you assume that this is minimal change disease without having biopsied them, the outlook is really good. A lot of them will relapse. Some of them will relapse one time. They might become frequent relapsers. Some frequent relapsers stop having relapses when they become teenagers. Others stop having relapses when their kidneys die. It's just hard to tell. there will be a certain population that will never relapse. So if you do general pediatrics and you're out there and you find some kid who has nephrotic syndrome, you can, if you feel comfortable and you know that it seems like it's just an idiopathic minimal change disease, you can treat them with steroids the first time. And then if they never have another episode, they never need to see a nephrologist. But if they do have frequent relapsing episodes, then I would suggest that you find a nephrologist to help take care of them. Let's see. Then you have your steroid-resistant nephrotic syndrome, which essentially is where you give them steroids and they don't respond. Usually before they reach the steroid-resistant stage, unless it is your podosin and nephrin mutations, they will usually become steroid dependent, where you put them on steroids and they respond, but then when you try to take them, wean off their steroids, they have another relapse. So besides your congenital nephrotic syndrome, focal segmental glomerulosclerosis is another one which is notorious. That is also a histopathologic diagnosis where you have these segmental focal areas that are sclerosed, and that's what's spilling the protein. And those kids will usually end up going into renal failure significantly fast. How do you treat steroid-resistant nephrotic syndrome? You repeat courses or you do a long prolonged prednisone along with adjunct medication. So you use tacrolimus, you use mycophenolate, you can use cyclosporin. Cyclosporin used to be used a whole lot more before tacrolimus became more common. They're both calcineurin inhibitors, but cyclosporin has a lot more systemic side effects than tacrolimus does. Focal segmental glomerulosclerosis is another common kind of nephrotic syndrome that you will hear a lot about. It can also be primary, but it can also be secondary from a bunch of diseases. Again, more commonly, secondary FSGS that we see more commonly in the pediatric population is usually reflux nephropathy and renal dysplasia. All others are more common in the adult population. FSGS has a poorer prognosis than your minimal change disease because and then if they have persistent hematuria and they are steroid resistant from the get-go, then again they can go into renal failure faster. We had a couple of patients here who had FSGS way back when that went into renal failure within 6 to 12 months of diagnosis. Now, having said that, we don't know how long they had FSGS before we actually found them. So you treat them symptomatically. The goal is still to decrease the amount of protein in the urine because you want to prevent the damage that happens from protein to the kidney. So you give them ACE inhibitors that decrease the amount of GFR, that decrease the amount of proteinuria. In those cases, you actually do try to decrease their lipids if they're old enough to get lipid-lowering meds because this is going to be more prolonged than your traditional minimal change disease. There are a bunch of protocols out there that you can use to treat them with adjunct medications. Any questions about proteinuria so far before we move on to hematuria? Okay. All right. Here come more questions.
10-year-old female coming for a well-child check is completely healthy with normal visits. UA shows specific gravity of 1.030, pH 6.5, 2 plus blood, and no protein. Of the following, the most appropriate next step is abdominal CT, DNA and complement measurement, BUN and creatinine measurement, with cystoscopy, and repeat UA in 6 weeks.
C.
I didn't hear, sorry. E? Yeah. What's wrong with this question? What did she come for? A well-child check, right? Should we be doing UAs at well-child checks? No. So when I was a resident, well-child urine analyses were part of well-child checks. And they got taken away by AAP for this reason, because it would generate a whole lot more anxiety, referrals, and all sorts of things with no symptomatology involved. Because there's 2 plus blood, which means nothing as far as you know. It's probably going to go away the next time, but during that time, it's going to cause anxiety to a whole lot of people. We will have to have her come back and all that kind of stuff. So AAP took away recommendations for doing screening UAs. Unfortunately, they are still done in the community. not just here, everywhere. And then they do generate a whole lot of consults where you just handhold and then send them back on their way, which is fine because as far as we're concerned, we're getting consults, right? But it's anxiety for parents. Sometimes they have to travel far to go see a nephrologist, and it's kind of not fair on them. Okay, so workup for hematuria is what we're going to talk about. And I'm sure some of the faculty have seen this slide before. So blood per toilet is what we're going to talk about right now. You guys have to guess how much blood is in each of these toilets. In mLs. How about this one? One is close. Who said one? Half ml. And this one. And 3. So it does not take a whole lot of blood to make your toilet red. But if a parent was to see this, would they freak out? Yes. But blood in the urine is very scary, but it's not as harmful as protein in the urine that you can't see, so nobody finds out about it unless you're having so much protein in the urine that your urine is frothy, right? So this is important to know, especially when you try to explain to your parents about microscopic hematuria and how you're not concerned, and even gross hematuria where from various diseases, because you can persist to have gross hematuria, which is very scary, but not as harmful unless it has proteinuria along with it. Okay, so you have your microscopic proteinuria, your gross hematuria that can be bright red and polar colored, right? So we're going to talk about the evaluation of hematuria in general and then cater the further workup depending on what kind of hematuria we find, because the causes differ slightly from one to the other. So initial history, you want to try and get just like any other history. You want to know the color of the urine, the duration, if they've had previous episodes, if they have associated pain or trauma, bleeding diathesis, because that will make you go in the direction more urology way, either stones or anything of that sort. If they have fever, swelling, joint pain, then you start thinking rheumatologic or autoimmune diseases. If they've had any antecedent or concurrent illness or weight loss, which kind of helps you delineate between post-infectious glomerulonephritis and IgA nephropathy. And if they've had weight loss, then you again think about more systemic diseases. There's a history of sinusitis or visual problems, any medications or food consumption, voiding habits, and menstruation, right? Because you also want to you want to be a tiny bit skeptical about this blood in the urine too, because it might be from false hematuria. Right? You want to look at vital signs with any physical exam, right? So you want to look to see if their blood pressure is high. If their blood pressure is high, it points more towards acute glomerulonephritis. If they have fever, how do they look? Or how is their growth? Or do they have poor growth? Because that would make you think about more chronic diseases. If they have rash, arthritis, edema, again, more autoimmune diseases. If they have impetigo or pharyngitis, or had a history of such, then you start thinking more of your acute post-infectious. And you want to do a genital exam because you want to rule out any local trauma or local rash or anything, irritation that might be giving rise to this blood in the urine. Okay, you want to find out family history. A lot of diseases run in the family, so you kind of want to look for, to ask about kidney stones or Alport's, polycystic kidney disease, any rheumatologic disease, and sickle cell disease, or even sickle cell traits, because those can also present with blood with hematuria. So a lot of your questions are general to everybody, and a lot of your questions are catered by which direction your history is going. Then you want to look at your urine analysis. You want to look at the color. You want to see if there's any clots, if there's hematuria just by dipstick, or there's gross hematuria. You want to confirm the presence of RBCs by microscopy, because your urine can look red but not necessarily have RBCs, right? It can have myoglobinuria, it can have hemoglobinuria, and then the pathology differs. So you kind of want to rule that out. And you want to see if there's proteinuria or not. And then you want to see if there's nitrites and leukocyte esterase, because urinary tract infections can also present with blood in the urine, and plus minus some proteinuria at least. So what next? So you did all your history, and you did your physical exam, you looked at the urine analysis. By then you will have had at least some idea of, at least you know whether this is just microscopic or it's gross. And if it's gross, then if it's bright colored or cola colored, and then you can kind of tease out further of your investigations and questioning based on what your differential is till then. So we can look at gross hematuria. It is red or pink color, okay? So first of all, it can be false hematuria. It can be drug related. There are some certain drugs that we all still use, so flagyl, rifampin, some sulfur drugs can cause you to have bright red urine. Food dyes, red beets, berries, those can also have red colored urines. Myoglobinuria, where your dipstick will be positive, but there'll be no RBCs when you send it for microscopy. And if you have had muscle injury, then you'll have elevated CPK. So there'll be other supporting evidence if this is false hematuria. You can also have hemoglobinuria. Again, your dipstick will be positive, but there'll be no RBCs on microscopy, but there'll be history of hemolysis. And if you get a CPC, then you might see evidence of hemolysis and vaginal bleeding. So those are all your false hematurias. If you've gotten to this point and you figured out it's false hematuria, then you just need to reassure him and do nothing further. Then you have your true hematuria that might be non-glomerular in etiology. So trauma, nephrolithiasis, or just hypercalciuria, even without evidence of stone, can give you blood in the urine. Sickle cell disease or trait, polycystic kidney disease. Again, a lot of these diseases you would think would have come to light earlier on in the kids' lives, but sometimes it just doesn't. And urinary tract infections, any vascular malformations, mechanical trauma, renal vein thrombosis, which is most common in your premature neonatal babies that have been stressed, abnormal tumors of the kidney and urinary tract. IgA nephropathy can also cause you to have clots in the urine along with gross hematuria, so that's something to keep in mind. Okay, so what further workup would you do if you had your gross hematuria that was bright colored? We just went through a whole bunch of differentials, right? So now you kind of will have to go down through each of your differentials and figure out which this might fit in. So you want to get a urine culture if you're suspicious that this is a urinary tract infection. You want a KUV to start with if you think this is either constipation related or may have some kidney stones, depending on where you are. Not everywhere do you have the ability to do spiral CTs, which is gold standard, but you could start with that. You want to measure a calcium creatinine ratio. So 0.2 is a great number to remember as far as nephrology is concerned, because even a calcium creatinine ratio of less than 0.2 is normal. When you're younger, it can go up to 0.5. So your babies and infants can have calcium creatinine ratios up to 0.5 or even 1. You may, if you go that route and you want to figure out what kind of stones and everything, you can get a 24-hour urine collection, which is called a stone risk profile. It's this fancy profile that gives you all minerals that are high and low in the urine that help with kidney stones detection and then further therapy. And then hemoglobin electrophoresis, if you think this might be a sickle cell trait that was missed, you might need to do a physical exertion test if you think this is either myoglobinuria or exercise-induced or whatever it might be. And if you think it's more local trauma or urologic malformations or vascular malformations, then you want to send them to urology. Okay. Then we come to our tea-colored or cola-colored. By default, we think that when their blood is cola-colored, it has kind of results from dysmorphic RBCs, and the idea is that most of the time it is coming from upper urinary tract, which means it has a glomerular etiology. So you might have RBC casts and dysmorphic results. The most important thing about RBC casts is if you just look at your urine analysis results in the computer and say there were no RBC casts, then it might not be true that there are no RBC casts. Casts disintegrate over time. So if you really truly want to see if there are casts or not in the urine, you need to take a fresh specimen of urine, spin it, and look at it under the microscope yourself to see if there are casts or not. So don't be surprised if you come around and say, hey, the next time this kid, please page me, and I want to look at the urine under the microscope. Because that's what you really need to do if you want to look for casts. Because if the urine sits in the lab for a long time, then the casts might disintegrate. And then oftentimes there'll be proteinuria and hypertension involved, which will point towards a glomerular cause. So these are a whole bunch of causes of glomerulonephritis. The most common ones that you will see are post-strep, lupus, IgA nephropathy, and HSP. And then the others are there, but they're less common than the above ones. HUS comes in spurts when they're usually in the spring season, May-ish, April, May-ish, more summer. So post-strep glomerular, and we'll talk about some of these in detail. So then you start thinking of these causes if you had fuller colored urine. Then you want to do further workup based on that, right? So you want to make sure that kidney function is okay. You're going to get some you're going to get their comprehensive profiles. If you're thinking more post-infectious, then you want to get your C3, C4s, along with lupus, you want to get your ANA and dsDNA. And then if you're thinking this is more secondary related, especially for our MedPeds colleagues, then you want to get your Hep B, Hep C, HIV. We also get our Hep B, Hep C, HIV if we are going to give them high-dose steroids and other medications sometimes, not just to determine the cause. You want to get urine studies, whether it's calcium creatinine or protein creatinine or whichever direction you might be going. If you haven't already gotten a protein creatinine ratio, you would get a protein creatinine ratio. 24-hour urine collection for protein, not usually done for our kids, especially our younger kids. Sometimes rheumatologists will get it for more quantification of proteinuria in their lupus patients, but adults still do a whole lot of 24-hour urine collection. You may want to get a throat culture to see, especially if you're thinking post-infectious GN, not because it would prevent anything as far as the post-infectious GN is concerned, but you still want to treat their strep if they were not treated to prevent traumatic fever. And then you may need a renal ultrasound if you're thinking there might be some anatomic pathology. You also want to get a renal ultrasound if you're thinking of doing a kidney biopsy to see what the kidneys look like. Okay, and then sinus or skin biopsy and kidney biopsies are done when warranted. So we don't usually biopsy our post-infectious GNs or our HSPs and our HUSs. There have been only 2 or 3 times that I have biopsied what turned out to be a post-infectious GN when they went into rapidly progressive renal failure, and I really wanted to find out if I needed to give them steroids or not. And some of them, depending on how sick they are and how hypertensive they are, may require admission in this group, the Glomerulonephritis group. Then you come to your microscopic hematuria. This you will probably more commonly see in your practice, whether you got a urine to figure out something else, or you're in a practice that still does urine analyses, you might see microscopic hematuria. Once you found an abnormal value, then you kind of have to evaluate it and go through it. So first of all, you want to figure out whether it's with or without proteinuria. Isolated microscopic hematuria, then the most common cause, honestly, that we see is dysfunctional voiding and constipation. Believe it or not, you can get enough constipated that you get into this holding pattern where you're also holding your urine, and then you get some microscopic hematuria as well. So you treat the constipation and the problem goes away. I think I treat a lot of more constipation in my clinic than I would like to. And then hypercalciuria, remember I mentioned you don't necessarily have to have kidney stones. If you had hypercalciuria before kidney stones or just by itself, you can still have microscopic hematuria. So you kind of want to have that in your differential when you're looking at microscopic hematuria. Thin basement membrane disease, where your membranes are thin and are just filling out RBCs. Again, thin basement membrane disease is a histopathologic diagnosis, but you can suspect it based on your clinical judgment. And then foreign bodies. And then you can have microscopic hematuria and proteinuria. Can also raise concerns for glomerulonephritis, probably more of a milder kind. Nephrotic syndrome can give you both hematuria and proteinuria. More commonly, your HUS, HSP, and lupus. So then your further workup obviously will depend on what you found in your history and what you're suspecting as far as your diagnosis is concerned when you have isolated microscopic hematuria. But when you have microscopic hematuria and proteinuria, you will follow your same algorithm you would for any other glomerulonephritis, because you want to rule out any of those as you would want to treat them faster, which is what we kind of already talked about, but I summarized it again since it comes up again. Okay, so now we're going to talk about some of the common glomerulonephritis that you might see in your practice as well as in residency. Most common is post-infectious GN. Most important kind of post-infectious GN we see is post-strep glomerulonephritis, which is why that comes up as a name more commonly than post-infectious GN is concerned. But you have to keep in mind that strep is not the only organism that can cause post-infectious GN. A bunch of viruses can cause it. Some medications can cause it. Tacrolimus is the most common one that we see that can cause problems as well, but it's most commonly your strep and other bacteria and certain viruses. So it can present with gross hematuria, it can present with edema, hypertension, and renal insufficiency. Depends on what spectrum they fall in. If they have any evidence of high blood pressure, then we admit them to the hospital because we want to fix that high blood pressure. As opposed to your nephrotic syndrome, this is also a fluid overload state, but this is an intravascular fluid overload state. This is the one time in pediatrics where diuretics is your first drug of choice to treat hypertension, because the kidneys are behaving not like they should and causing you to retain salt and water, and hence you have intravascular volume expansion, and you want to diurese them to make their blood pressure better. And then other symptomatic management as might be needed if they have associated acute kidney injury and are hyperkalemic and all that kind of stuff. It's most commonly seen in boys 5 to 15 years of age. So this age is slightly higher than your nephrotic syndrome age that boards like to ask. So that's kind of how you remember those are your toddlers and your preschoolers, and this is more your kindergartners. Most patients recover in about a week. Their hypertension can present for stay for 2 to 3 weeks. So sometimes you send them home with some antihypertensives as well, and then monitor them in your clinic afterwards. And your UA, abnormal UA can persist for years. You can have microscopic hematuria for at least up to a year, if not 2 years. And that is important to remember for yourself as well as to educate your families. You will have a low C3 and a normal C4. This is a board question for MLEs as well as the pediatric boards. Biopsy is usually not indicated unless they're presenting with a not classic picture. And you want to manage them by treating their strep infection, if not already treated, to prevent traumatic fever, and then manage their hypertension. IgA nephropathy is the most common cause of gross hematuria. This is also a board question sometimes. It usually presents from 10 to 30 years. Mostly in Asians, whites, and boys are affected more than girls. Recurrent episodes of gross hematuria that coincide with acute illness. This is the major difference from post-infectious GN. In post-infectious GN, your classic presentation is they had strep a couple of weeks ago, and then they present with this dark-colored urine out of the blue. Your IgA nephropathy will always have blood in the urine, whether it's cola-colored or bright red or clots, when they just get sick. And it will happen with any illness. And if they give you that classic presentation, then it most commonly is IgA nephropathy. And it can present with microscopic hematuria, proteinuria, or gross hematuria, as we talked about. And then as their illness gets better, the gross hematuria goes away, it happens again. So if you do diagnose somebody with IgA nephropathy, you really have to educate those parents as well that this will happen again and again. Remember how much blood was in those toilets? It is scary when you have gross hematuria. So if you don't educate your parents well, every time the kid will get sick, every time they'll have blood in the urine, it'll freak the parents out. It would freak anybody out. So you kind of have to educate them really well. IgA nephropathy can have a varying course. You can go into renal failure very fast, or you may never go into renal failure, or you may go into a slow renal failure. So it just depends on how they present. And mostly you do symptomatic therapy. You use ACE inhibitors either just for proteinuria or for proteinuria and hypertension. Fish oil has been shown to have some benefits. So a lot of patients will ask you if they can give their kids fish oil. The dose that was beneficial was really, really high. So when they're younger, it's hard for them to give the kids the pills because they're big horse pills. When they get older, their sweat starts smelling like fish, so kids won't want to take it. So I don't push it. I was like, if you want to do it, you do it. It's not going to harm them. It might just benefit them. So steroids are controversial. Sometimes if you biopsy them, if they have significant crescentic disease, which shows acute inflammation, then some steroids might help, but most of the time they don't. HSP nephritis is a common one, but HSP itself is more common than HSP nephritis. And I bring this up for two reasons. One, you will see it, and not all HSPs will have renal involvement, and unless they have significant hematuria and proteinuria, then they either need to be treated by general pediatricians or they may possibly go to rheumatology. The only time nephrology really needs to get involved is if they have significant persistent proteinuria. And a lot of times we also just see them and then handhold them till the proteinuria improves. But sometimes we have to start anti-proteinuric agents like lisinopril to help them. Steroids have not really been shown to have benefit as far as proteinuria is concerned, but they do the short doses to help with abdominal pain, so you might want to consider that for that reason. You do want to check the urine analyses every depending on how often you're seeing them and if they have any abnormalities or not, because sometimes they may not have proteinuria and hematuria right at the get-go, but might develop it with somewhere in between their disease. They don't necessarily go into chronic kidney disease a whole lot, but there are certainly some cases out there that they might proceed to chronic kidney disease if their proteinuria persists. Again, remember, HSP nephritis has the same histopathologic findings as IgA nephropathy does in these patients. So essentially, it's like a systemic IgA. Then you have other diseases like MPGN. Again, all of these are histopathologic diagnoses, and MPGN usually comes to light when you have what you suspected was a post-infectious glomerulonephritis, but it doesn't get better. So post-infectious glomerulonephritis is a short-term disease. You have low complement level, but your complement levels should come back up in your 6 to 8 weeks, and your hypertension should get better, and your hematuria should become microscopic. If none of that happens, then you want to biopsy them, because then you worry about MPGN, which can have a much poorer prognosis than post-infectious glomerulonephritis does. So then, based on the biopsy, there are different classes of MPGN, and based on those classes is how we kind of end up treating them, and kind of go from there. And another red flag towards MPGN, if your patient is not getting better from post-infectious GN, is that a lot of them will have anemia as well. I'm going a little bit faster because I'm running short of time. Okay. And for MPGN, one of the therapies is prolonged steroid therapy. And if they do present with significant abnormalities, and depending on how bad their histopathology looks, they might go into renal failure faster than anticipated. Rapidly progressive glomerulonephritis by itself is a clinical diagnosis based on the fact that they presented with what looked like glomerulonephritis, but now their creatinine is rising fairly fast and they're going into renal failure fairly fast. We will biopsy these patients, and when we biopsy them, a lot of time we will see crescentic GN, and that's when we can call it rapidly progressive crescentic GN. But we can't call it crescentic unless we've seen the crescents ourselves. And the reason why we want to see crescents is because then we know how to treat them versus not. Almost all of them will progress to end-stage renal disease, but if we catch them early enough and we treat their crescents, there might be some nephrons left that we can maybe put them into late CKD for a while. It is rare in childhood, but having said that, I have seen a whole handful, 2 handfuls, so it's not that rare. And they can present with gross hematuria, edema, anemia, basically get like any kind of glomerulonephritis, but then the creatinine just keeps on rising. Sometimes there might be confounding factors like drugs involved on top of having glomerulonephritis, which causes it. But again, like anything else, a good history, a good physical, and then looking at the whole picture helps figure that out. So any of these can lead to rapidly progressive glomerulonephritis. Depending on where they fall and what kind of disease they may have, we might want to get more serologies, like look for anti-GBM disease or Wegener's or Church-Strauss polyarteritis. Now, all of these are significantly rare in children as compared to adults, but we still see them. We are in Louisiana. We see a whole lot of things in kids that we really shouldn't see. So then you might get serology based on what you think is going on, or sometimes you might get serology based on maybe it is this and I don't want to miss it because I want to treat it fast. Lupus nephritis you see a whole lot more commonly than you see RPGN. A lot of lupus, 20% of the lupus patients will have onset in childhood. Sometimes they will have lupus-like nephritis but not have any other symptoms or serology of lupus till much later in life. We had a whole bunch of those here in a few years ago, and you essentially biopsy them to see what class of lupus nephritis they fall in, and then their therapy is in conjunction with rheumatology. Then you have your ANCA-positive GN, which is rare in the pediatric population but can occur, and then you kind of, again, treat them with rheumatology. Wegener's is another one. It's kind of rare. ANCA is sensitive and specific for Wegener's glomerulonephritis, another board question. And then you have your anti-GBM, which again is kind of rare in pediatrics. Maybe you'll see an adolescent that might show up with it. Usually preceded by the URI, presents with acute kidney injury, then progresses to renal failure. They may or may not have hemoptysis along with it. And that might be almost towards the end. Sorry, a few seconds. Anti-GBM is important because if you have antibodies, then you want to plasmapheresis them to get rid of those antibodies and treat them that way. Question, another one. There might be a couple more, and then we're done. Sorry.
A 6-year-old boy presents with Coca-Cola colored urine. His mother reports that he had a sore throat 10 days ago. His blood pressure is 136/88 and has had mild swelling of the face and lower extremities. Of the following, the most likely laboratory finding is A, a low C3 complement level, B, normal UA, C, positive ANCA titer, D, positive ANA titer, or D, positive urine culture.
This is a board question. This is a long one.
The parents of the 10-year-old girl present to your office for a second opinion. The girl has been having asymptomatic microscopic hematuria for the last 18 months. Her records show a normal physical exam on regular documented visits, normal renal ultrasound, and a normal serum chemistry, most recently checked 1 month ago. She has multiple urine analyses showing 4+ blood by urine test strips and 20 to 50 RBCs per high-powered field. There is no family history of autoimmune diseases or renal failure. Her physical exam reveals that her temperature is 37.9 degrees Celsius, heart rate of 76, respiratory rate of 17, and blood pressure of 110/60. She has a normal growth parameters and normal physical exam. Her UA demonstrates a specific gravity of 1035, pH of 6, 4+ blood, and no leukocyte esterase protein or nitrites. Her urine microscopy shows 50 to 100 RBCs per high-power field, less than 5 white blood cells, no crystals or bacteria. Of the following, you are most likely to inform your parents that asymptomatic microscopic hematuria is common in school children. Persistent microscopic hematuria indicates significant risk for renal failure in the future. Proteinuria will increase her risk for progressive renal disease. She will need renal biopsy for evaluation of hematuria, and she will need a urology referral. Somebody else can answer.
So this is the kind of question that you get in the boards where you sometimes have to use your rule out, right? So is the first statement true? No, right? By itself, hematuria is scary, but it doesn't usually harm you. Is the second? Oh, sorry, the second one is what I was talking about when I meant the first. Second one is not true because it doesn't lead to renal failure. Is the first one true? No, right? Because microscopic hematuria is fairly common. What about the third one? Yep, remember I said proteinuria is harmful to the kidneys? So that's your right answer. We don't necessarily do biopsies if it's microscopic hematuria because we're not going to find much that we can treat anyway, so why stick a needle in somebody's kidneys? And there's no need for her to have urologic referral, right? So these are the kind of questions. Sometimes these are these big questions where in the end you just have to rule out stuff. Maybe we'll skip this question for now because we're running out of time and I want to have my obligatory picture for those of you who remember my group. But anyway, questions? None? You guys now know what to do with hematuria and proteinuria. Yay! Well, thank you for listening.